Hello, everyone. Welcome to RegenMedGlobal, the podcast. My name is Cheyenne. Today, we're here to discuss a major clinical trial for treating an inherited blood disorder, sickle cell disorder, using stem cell gene therapy. Leading this research and speaking with us about this, we have UCLA Professor for the Departments of Microbiology, Immunology, and Molecular Genetics, Pediatrics, Molecular and Medical Pharmacology. We have Dr. Donald Kohn. Dr. Donald Kohn, thank you so much for joining us today.
Glad to be here.
Yeah, thank you. Before we get started, I'd love to have you maybe start off just by telling us a little bit about your background.
I'm from Chicago originally, went to the University of Illinois for college and was a biology major, stayed around for another 2 years and got a master's in microbiology. Then I went up to Madison, Wisconsin for medical school. So I did 4 years of medical school. And then I did a pediatric residency. So I'm a board certified pediatrician. Then, but all the way through, I was very interested in research and science. And so after my pediatric training, I went to the National Institute of Health and did a fellowship in pediatric immunology and started working on gene therapy as my project for my fellowship 40 years ago or so. Basically, I've been doing the same experiment ever since. And so trying to develop techniques to be able to treat human blood diseases.
Can you just give us a little bit of an overview about what sickle cell disease is?
So sickle cell is a genetic disease, and so you inherit it from your parents. And it's the problem is that one of the genes that makes up the hemoglobin molecule has a specific mutation in it. Over time, patients with sickle cell have progressive organ problems from these repeated insults from sickle crises. So patients with sickle cell have these episodes that can occur as often as every month, sometimes less depending on the patient, that require often hospitalization. It's also very disruptive to trying to lead a normal life. You can't hold a job, you can't go to school when you're in the hospital, a week every month. And so it's a very, very disabling disease.
Can you give us an overview about the clinical trial?
If you have sickle cell, but you continue to express more fetal globin, you're much milder. So it turns out that fetal globin prevents the sickle globins from sticking to each other and inhibits that. So most of the gene therapy approaches that are out there, and there's almost a dozen now, most of them are trying to recreate the situation of increased fetal hemoglobin. And so, for example, one trial has made a virus that carries that fetal hemoglobin gene, puts it into the patient's stem cells, so they make more fetal hemoglobin in their red cells. And that would prevent sickling. And so the approach we're doing is a variation of that. So we're putting into the patient's, so we take bone marrow stem cells from the patient, which are the cells that make our blood. In the laboratory, we're adding a copy of the beta globin gene that's been modified in the laboratory to be like fetal globin and prevent sickling. So when we transplant those cells back to the patient, when they start making red cells, they'll express that anti-sickling globin and their red cells won't sickle.
Can you tell us a little bit about how that procedure would look like?
For the gene therapy, the way we get the stem cells from the patient to begin the process is if we give them, there's some medicines we can give that sort of cause the stem cells to leave the bone marrow and go into the bloodstream. And so then to collect them, we'll put in a big IV line into the patient for just, for that day. And some of their blood, it slowly goes through that IV into a machine that sort of separates off the stem cells and returns the rest of the blood back to the patient. So it does it very slowly over 3-4 hours. Over that time, their entire blood volume will circulate through the machine, but a little at a time, so they don't have low blood pressure. But over that process, you can collect many, many stem cells that came from the bone marrow that can be used. It then goes to, we have laboratories that are called Good Manufacturing Practice, or GMP, which are clean rooms. So you've probably seen pictures of people making computer chips where they're wearing gowns, gloves, masks, they're all, in their sterile spacesuit. It's like that because we don't want to risk contaminating the patient's cells. And so we then take them through a process where first we select out the stem cells from all the blood cells we collected. Then they're put into culture. They go into a bag with growth medium, and they put into an incubator overnight. The next day, the virus carrying this anti-sickling gene is added to the cells, and over that next night, the virus delivers that gene into the stem cells, right into their DNA. So you're adding to the DNA of their stem cells this modified version of beta globin that prevents sickling. So it's just 2 days in culture, then the cells are frozen down. And then we freeze most of the cells like in a little bag, a little plastic, like seal-a-meal kind of bag, but special plastic, so it won't crack or anything. But we also freeze a few vials of the same cells that we then test. So over the next month or so, we'll run a lot of tests on a sample of the gene therapy stem cell product. Are they sterile? How many cells are they? How many took up the gene? Do they grow in culture? We have a whole list of specifications that the cells need to meet to be able to be used for the patient. So that takes about a month and a half or so. When it passes all the tests, then we can do the actual transplant. So the patient comes back to the hospital and we'll get those cells given to them. But before we can do that, we have to again give them chemotherapy. Here we're trying to use it to wipe out the bone marrow. We're going to give back the cells. We want those to repopulate the patient's bone marrow. And so that's the heavy duty, hard part of this procedure. They're getting a very strong chemotherapy drug that is necessary to make the space for the treated cells to grow. But over the next several weeks, the patient's going to have significant side effects from the chemotherapy. They can, their blood cell counts will drop down, so they'll need transfusions. They might need antibiotics. Their hair may fall out. They may have nausea. So a whole list of problems from that. So it's nothing that we take lightly, but it's it's part of the patient's decision whether they want to go through all that for the possibility of having their sickle cell disease eliminated. So after the chemotherapy is given, we give them a day and a half to make sure it's all out of their body. And then we take those cells that we froze in the laboratory 2 months ago, bring them to the patient's bedside, thaw it out, draw it up into a syringe, and then just slowly inject them over 5-10 minutes through their intravenous line. The cells will circulate through the bloodstream and make their way back to the bone marrow and start growing. So now they've gotten their chemotherapy, they've gotten the stem cells infused into their bloodstream, and now we wait. So over the next month or so, they're going to get sick from the chemotherapy. So they're going to be in the hospital on a bone marrow transplant unit where there's, it's very intensive nursing. So there's, each nurse has one, maybe two patients because they're requiring a lot of medical care over the next month. They may be on antibiotics. They might need a transfusion every other day. They may stop eating because of the chemotherapy, so they might need intravenous feeding. So there's a lot going on in that next month. And so this is what I do for my clinical practice for all these different types of diseases. And so we use the same approach, in this case, transplanting from the patient's own bone marrow. And so if all goes well, about 3 or 4 weeks afterwards, they're feeling better. Their blood counts are coming up as the stem cells are making new blood cells. And they typically can leave the hospital a month and a half after the transplant. And by that point, we can already start looking in their blood, are they making new blood cells with the gene we put into their stem cells? So even at 1 month, we can start getting a readout. And by about 3 to 6 months afterwards, we will know how many cells took with the gene, and are they making red cells that don't sickle, and is the patient doing well? So it takes minimum of 3 to 6 months to have a gauge on it. And in the study, we typically will follow the patients initially for 2 years and record how many sickling crises did they have, before the treatment and after the treatment, and how many transfusions might they need, and what other complications they had. And so, the trial has a lot of measures that we do to make sure the patient is safe and to try and assess was it effective to help their sickle cell disease.
Have you guys had any patients yet that you're currently evaluating, and any results you're able to share with us as to what you've seen so far?
We treated our first patient in 2015. And over the course of the year afterwards, it was clear that it really didn't work, that we saw almost no cells left in her bloodstream with the gene in them. And during that time, Bluebird Bio was doing similar trials and seeing kind of the same result, that it wasn't really working. The cells weren't taking. And so they, over time, and other people in the area, made a number of changes, and the Bluebird results got better. So we modified our trial, which took about 3 years to come up with how we wanted to change it, do the laboratory work to show that it made the gene transfer better, get the FDA to agree to allow us to change the protocol, go through all the various committees, treat the next patient, and then it was COVID time. So the second patient got treated in 2020 in the middle of all the chaos of COVID when we were only coming into the hospital to see patients and not do, other than that everyone was hunkered down. So we treated a second patient in 2020, and he's done quite well. So I would definitely consider, from my standpoint at least, I think he would agree, a success. So he was a mid-20s man with sickle cell disease who went through the sort of the version 2.0 of the approach. And now he's 3 years out, and he hasn't had any sickle crises since then. He's got a good number of cells in his blood and in his bone marrow with the gene we put in. And so we hope that we've eliminated his sickle cell disease.
Are there any other kind of benefits that you guys expect patients to see through this clinical trial, or that particular patient to be able to see?
Yes. So he's actually a very fit man, and one of his problems was fatigue. He tended, sickle cell disease used to be referred to as sickle cell anemia because some component of it is low blood counts, but people felt that didn't capture the whole of the disease, like the pain crisis. So that the term disease has replaced sickle cell anemia. But he had a significant amount of anemia. So he needed transfusions from time to time, and he just didn't have a lot of energy because he had a low amount of red cells. Well, that's come up significantly, sort of into the low end of the normal range. And he tells us he has much more energy and just feels better. So he has sort of a general sense of feeling better, which is what everyone's looking for, I think, when they go to the doctor. So I can't speak for him directly, but having spoken with him, multiple times, obviously after the treatment, I think he benefited from it clinically and in meaningful ways to him.
Is this like a one-time treatment that it'll last for your whole life, or is it something that needs to be done every so often? How does that work?
The intent is that it's a one and done. And so once you do a bone marrow transplant, that's the beauty of stem cells. So stem cells have the ability to divide and reproduce themselves forever. So it should be a lifelong source of these gene-modified stem cells. We won't know that till we follow patients 30, 40 years. But the ones we've treated in other studies who are out 15 or more years, we've seen no drop-off at all. So we hope it's a one-time treatment. And that's the only reason you'd go through it, because that month after the treatment is pretty rough for the patients. But the hope is that you're then going to have a lifetime of better, improved health after you've gone through a difficult month after the transplant.
Okay. Who would be considered an ideal candidate for this clinical trial?
The ideal candidate would be someone in their 20s. Currently, we're just treating adults. So someone relatively young in that age range who's had a lot of problems from sickle cell, but still has good heart, lung, kidney, liver function, et cetera. And it's always nice when patients understand. I'm very happy when I meet with a patient. They say, well, I've been reading all about this, and I have a lot of questions for you. I say, great, because this is still quite experimental, and we're doing research. We're trying to find treatments, but the more the patients understand the possible benefits, the possible risks, the alternatives, the better informed they are. That's important. So that's we look for young, healthy, enthusiastic people who have self-educated on their disease and on these treatments.
Are there any concerns or risks that people should be aware about if they were considering this clinical trial?
So one of the first ones that comes to mind is one of the side effects of the high-dose chemotherapy can be that it can cause infertility. And so the chemotherapy, besides wiping out the stem cells in the bone marrow, in males can affect sperm production, women can affect egg production. So it doesn't affect their sexual function, but it can affect their fertility. And so we offer patients before they go through all this, once they've come into the trial, we've had the testing that says that they meet all the criteria to either bank sperm or eggs for them to, fertility preservation as it's referred to, so that they could, after the treatment, if they chose to have children, they would have that. And so that's, that's obviously a huge issue, depending where the patient is in their life. We've had some people say, well, I don't want to take that risk at all and decline to have this. And so that's the number one risk. Number two risk, I'd say after that, is the risk from the chemotherapy. We talked about it a little bit. When we go through the informed consent process, we have pages and pages that talk about everything the chemotherapy might do and try and tell every risk potentially, but then put it into proportion. but that's only in 1% of people, or that's only in 5%, but we want, again, people to know the risks. Another issue is the virus that I talk about that we use to put the gene into the cells is actually derived from the HIV/AIDS virus. So that obviously, that sounds scary. And so the HIV virus was cloned in the laboratory, meaning it was put into a form we can manipulate it in the laboratory. So we can remove all of the genes from the virus other than its very ends and put the beta globin gene in there. And that will carry the gene into the cells like HIV infects into T cells. It doesn't have any of the information to make new virus. So no one who's gotten these types of virus, and probably 1,000 or more people worldwide have gotten this type of virus for different gene therapy. It's never caused a problem like causing AIDS. So we think that risk really is zero, although one never knows. But that's something to know. And then a tiny side effect of that is certain HIV tests done on the patient after they have the gene therapy might pick up the virus. And there was a case where a patient who had this type of gene therapy for a different disease, and they had a fever, and someone did an AIDS test and they thought they had AIDS, but in fact they were just picking up the gene transfer virus pieces. And so we inform patients of that risk. If someone's going to do an AIDS test, there are ones that can be done that won't pick that up. And then, then again, in the consent, we have several more pages of all the other risks. For getting the stem cells collected and for getting the transplant, we have to put in a big intravenous line, like a central line. Those can occasionally have clots or other problems. And, so there's a whole list of things. But, most of the time, everything goes right. But there is a risk of something bad happening. And, we frankly say there is a small chance that you could die from this procedure, from a side effect from the chemotherapy if you have an unusual reaction to it, or other things. So it's definitely nothing to do at all lightly. And so, for example, when we are talking to a patient about this study, we will talk with them multiple times about it before we even start thinking about enrolling them in the study. We really want to make sure as much as possible they understand the risks, the potential benefits, what we know, and go into it as much as possible with, voluntary decision that they understand the risks, but they hope the benefits will outweigh those, and so they go forward with it. But it's an ongoing process to try and make sure the patient is as educated and knowledgeable and informed going into this as they can be.
Let's say if someone is interested, right, and they want to enroll part of this clinical trial, how can they go about doing that?
Over the course of 5 years now, we've treated 3 patients, and we have the 4th one about ready to go. So we have many people who have referred themselves, or their doctors have referred them to it. So we have a list of people who are potential subjects. Once this trial is done, there will be other ones for gene therapy. And so the way to do it would be to contact our group at UCLA, and I'll tell you how to do that. And, we would intake the information about the patient, their age, their disease, some general question about their health status, and put them on our list. And then when it comes time to select the next patient, we kind of go through the list, and, we start at the top and find people who we think, from what we know so far, would be eligible, would be good candidates. We're tending to try and enroll people from the Los Angeles, Southern California area if we can. Just logistically, it makes it easier if the patient is local. And also, most of the funding for the trial comes from California Institute for Regenerative Medicine. That's the California Stem Cell Institute. And they have very much of a commitment to medicine in general, but California in particular.
Perfect. And you said it's funded through the program?
CIRM funds the clinical research trial, and that pays for all the medical bills associated with the trial. It won't cover unrelated medical expenses, but when the patient, for the procedure I talked about getting the stem cells mobilized and collected, the chemotherapy, the hospitalization, that's all covered by the grant.
Are there any final thoughts or any finishing words that you'd like to go and add?
I've been doing this kind of stuff for 35 or so years, and for the first 28 or something, that nothing worked. And it's certainly for sickle cell, people have been trying to develop these kind of therapies for, again, that long, and all of a sudden it's working. And so gene therapy, besides, we talked about the application of sickle cell, but other gene therapies have been restoring eyesight, are treating severe neurologic diseases in children. Several of those that would be severe neurodevelopmental defects are being treated, and so there's a lot coming along. And as I said, it's less now of a scientific challenge and more of a economic, financial. How can we make these things available? So hopefully we'll be able to solve those problems as well as we did with the technical challenges.
Dr. Kohn, thank you so much for your time. Thank you for your contribution. Thank you for all this information.
Great. Glad to talk about it.